Hi, I'm Dr. Stewart, and I want to thank you for taking the time to watch this DVD. The purpose of this video is to help you understand what weight loss surgery is and what the different options are. Since there are a number of procedures out there, I find that it's useful for patients to begin to think what are the differences between the procedures and how they may compare to one another so that they can make the best choice for their weight loss goals. This video is not intended to replace a one-on-one consultation with me. I think it's very important that we have a chance to sit down one-on-one and discuss your weight loss goals and decide how we can best meet your needs.
Hi, I'm Sue, and I'm Dr. Stewart's nurse practitioner. I've been working with Dr. Stewart for about 4 years now. I do many things for Dr. Stewart. I help you with your pre-op diets, try to get you into the right behavior mode and exercise mode so your surgery will be the most successful for you. Really try to problem solve with you. Do non-surgical weight management as well. We run a program called OptiFast, which is a very low calorie diet which will help you lose about 3 to 5 pounds a week. Very exciting, great results with our patients who come through that. If you choose to have a lap band surgery, I help with the lap band fills here in the office, so you'll be seeing me quite frequently if you do have a lap band placed. I help Leah with seminars and with patient scheduling. I also help Leah get seminars together and support groups. I help Dr. Stewart in surgery. You may see me like this on Monday or Wednesday on your surgical date. I do help him in that respect also. Weight loss is a process. It's not a procedure. It takes a lot of dedication and a lot of behavior changes. And as a team, we're very dedicated to helping you through that process. There are many behaviors that need to be changed to keep that weight loss off permanently, and we are here as a team to work with you to keep that weight loss off. It requires follow-up visits, follow-up phone calls, labs, vitamin supplementation, making sure you're taking the right protein. You have a question, you call us, you email us. We are always there for you because you're part of our family once you come into our lives here. I've been in nursing since I've been 19, and I have treated patients with their high blood pressure and high cholesterol. I have seen the agony in their lives because of carrying extra weight, and I always felt like I was putting Band-Aids on the problems that they were having. For the last 4 years working with Dr. Stewart in bariatrics, we are now getting at the beginning of the problem. Where is this high blood pressure coming from? Where is this high cholesterol coming from? From the extra weight. I don't want to put a Band-Aid on the problem. We want to try to help fix the problems, and we are so committed. In the 35 years in nursing, I have never felt so committed to what I do than working in bariatrics and helping you to achieve the weight loss that you need to live that full life that you deserve.
You see this slide up here, and it's a definition that our society came up with a number of years ago for what obesity is. And I think it illustrates our approach to obesity. You see there's only one word that's underlined, and that is the word disease. Our approach to the treatment of obesity is approaching it as we're treating a disease. And I think if we start on that basis, then we have a whole lot better chance of being successful. The next slide is a slide that describes something we call body mass index. Who's heard of that before? Okay, so body mass index is something that when we get to this talking about treatment of obesity, I mean it's sort of like a measuring stick. It's an index, is what body mass index, and it's just a starting point really. But what it does is it helps us to have a place to start. Where are you now, and where should you be, or where, what is our goal? Where are we trying to get to? And so you see the equation there at the top of the slide says body mass index is your weight divided by your height. but it's in metric system. So we don't understand it real well because we don't know how many meters tall we are, but that's just the way it's set up. And what this does is it helps us to help people understand where they are and how their weight can affect their health, okay? If you, in fact, the term morbid obesity denotes that there's some morbidity there. And morbidity, in general terms, just means there's illness, okay? And so morbid obesity, by definition, means that you're overweight enough that it affects your health. Medical comorbidities, what does that mean? Well, these are the things that affect your health. And so a comorbidity is a disease or a health problem that goes along or is associated with obesity, and that's all it means. But it gives us some idea and gives you some idea of what kind of frequency we see these problems arise with obesity and a body mass index of 35, 40 or greater. So one of our goals as we're treating obesity is to treat these things as well, right? And so a lot of you probably maybe seen a program on television or read an article or something that says that obesity surgery, maybe gastric bypass or one of the other procedures we're going to talk about today, if one of these surgeries can help eliminate diabetes or something along that lines. And there is a lot of data and statistics to show that, and we're going to talk about that a little bit later today. But it's true. If you treat the obesity, then a lot of times these things will improve or maybe resolve altogether. Another goal, or I'd say a combination of goals, is to help people live longer and to live a better quality life. As this graph shows, people who have morbid obesity, and you can see as across the bottom, as the body mass index goes up, your mortality rate goes up, okay? And in fact, you can see that curve gets kind of steep once it gets beyond a body mass index of 35. And so what that means is basically once you have a body mass index of 35 to 40, your life expectancy goes down significantly, okay? But beyond that, probably a lot of you would say, it's not only affecting, my health in this way, but it's also just affecting the way I live, my daily activities, my performance at work, my performance as a parent or whatever. I have a difficult time doing what I need to do. And there are some things that I just don't do because I can't. Okay, what is it we're trying to do with surgery? What is it we're trying to accomplish? Okay, and so you can see on the slide some figure, a man, and in one picture he's got a really giant hot dog, and the hot dog gets smaller as he gets smaller. But under that it talks about energy input and energy output. Okay, so it's intake, I should say, and output. And it's really kind of an equation. So you see in the first picture where his hot dog's really big, his intake is greater than his output. In other words, he's taking in more energy, and we measure that as calories. So you say calories are greater than calories out. Well, what happens there, we store the excess energy. And how do we store it? We store it as fat. That's just the way our body works, okay? So any increased energy that you take in that you don't need, whether it be as sugar or fat or protein or whatever, our bodies have a way of converting that into fat, and that's the way we store it. So again, going back to our original slide where we said obesity is a disease of excess fat storage, that's really what we're trying to get at, right? It's, we want to lose weight. When we say we want to lose weight, what are we really saying? We want to lose that excess fat, okay? We don't want to lose muscle and bone and things like that because we know we need those, right? So what we're really getting at is fat. So you see that at the very bottom it says fat accumulates when calorie intake is greater than calories burned. And that's just a very basic thing. So the question is, okay, how do we reverse that? Well, you have to flip the equation. So on the this side of the slide over here, you see we've kind of flipped it, and the calorie output, or the calories burned, is greater than the calorie intake. And what happens there is our body then has to go and get those calories we've stored over time, or that energy we've stored over time, and begin to burn it. And that's a process we call ketosis. Okay? Ketosis is the process that our body goes through when we're burning fat, breaking it down, and using that for energy. Okay? And so our goal is to get into a state of ketosis and stay there long enough to burn most of our body fat. Not all of it, because we need some body fat, but to burn most of the excess. You might say, well, we can do that without surgery. And it's true, you can. But certainly the higher the weight, or the higher the body mass index, the more difficult it becomes, right? Because how do we increase our energy expenditure, or how much we burn? Exercise. Well, that gets pretty difficult at some point to really exercise, because you're overburdened with the extra weight, which puts an extra burden on your heart and the rest of your body, maybe your knees, maybe your back, and so exercising or burning more calories becomes much more difficult. So you see exercise on there. You see diet on there. I'm sure nobody in here has ever gone on a diet. Okay? I'm sure nobody here has ever gone off a diet. Right? Okay? And one of the things that I want you to understand today, or that I'm going to try to emphasize, is that surgery is about changing your diet. Okay? Not going on a diet and then getting off someday, but about changing your diet permanently. Because we all know what happens when you go on a diet and then you get off of it, right? The difference between what I'm showing here now, what we'd call conventional therapies or non-surgical treatment, and the difference between surgical treatment that we're going to talk about today, is the long-term results, okay? Because we all know, and we've all seen the TV shows, and we've all seen, various things in which people lose a lot of weight in a relatively short period of time. But what I'm telling you now is, and I think you already know, that statistically, the percentage of people who do that are successful long-term is very low. The success rate, the long-term success rate for significantly obese individuals is less than 5%. And our goal, again, and the reason we do surgery, is because we want a long-term solution, okay? Who should have surgery? Who's a candidate for surgery? And I think that's a question that, let me say the question has been there for a long time. The answer, I think, is changing and evolving a little bit. But what I've put here is really sort of the basis of the answer, and it relates to a consensus conference that was put together by the National Institutes of Health. They said that you should consider surgery if you're at least 100 pounds overweight. Now that would be based upon the Metropolitan National Life Insurance tables that give you ranges for ideal weight, right? So ideal weight was still something we looked at the time. Now I haven't really talked about ideal weight today. I talked about body mass index, right? So body mass index today is considered more the gold standard, the measure that we use, as opposed to ideal weight or life insurance tables. But the life insurance tables are, based upon who lives the longest, and therefore have some bearing on who's healthier, right? But you can see that body mass index of greater than 40, and I'll just tell you that body mass index of 40, is roughly about 100 pounds overweight. I mean, we're talking about the same group of people. If you're saying 100 pounds overweight or body mass index over 40. Or they said if your body mass index is over 35, remember that's the category we talked about, severe obesity, and you have comorbidities. That's why I put that slide up earlier about comorbidities, so that you kind of understand what we're talking about. Because one of the things that we're going to do, if you guys decide to pursue this, we're going to look at your insurance, and we're going to say, okay, and if your body mass index is between 35 and 40, we're going to have to provide them with documentation that you have one of those things on that list that I showed you earlier, okay? Most of the time there's a caveat that you've tried to lose weight on your own, okay, in some way, And as far as the NIH was concerned, it just meant that you had to have had a bona fide attempt at dieting. Okay, your insurance company may throw something in there like you had to do it under a doctor's supervision or something like that, and qualify it a little bit differently. And they may qualify it in terms of the number of months that you did it and the documentation and all that. But and then there's other things just about, are you healthy enough to have surgery? Are you mentally stable? Because we're going to change your life here. In a way that, kind of dramatically, because eating is part of your life. And, for some people, they don't react real well to change. Are you going to be able to cope with that? So, a lot of times there may be a requirement, say, of an insurance company that you undergo a psychological evaluation just to make sure that you are mentally stable enough and are able to cope with those changes. Earlier when we talked about what is it to be a candidate for the surgery, in 1991, the NIH said ages 18 to 60. Well, things have, that's 1991. It's been it's been 18 years. We have better technology, so we're operating on a lot of older patients. And you're right. Certainly since 1991, we've seen a significant increase in the adolescent population. I personally, in my practice, do not do what I would consider adolescence. Okay, so I generally say, for me, 16 or older. I think it really comes down to physical and mental maturity, and whether or not they can make it. Personally, I don't see that as a problem. I think that, and the reason I would say below 16 for me is because of the hospitals where I work. We don't have all the things in place for adolescents that they would need. Well, I've done patients in their early 70s. I don't know, I can't tell you what the oldest person has ever had surgery, but I will tell you this. I definitely favor something less invasive as people get older. So I'm not as interested in doing duodenal switch as someone who's 70 years old. Number one, I do 4 different surgeries, and that makes me a little bit different than other surgeons. There's some weight loss surgeons that just do 1 surgery. There's some that do 2 or 3, but at least in this part of the country, I don't know anybody that does all the different surgeries that I do. Okay, and so my practice is a little bit unusual in that I present more choices to my patients. And I do all of these surgeries commonly. In other words, I don't have a favorite surgery, and I don't really try to choose or impose something on my patients. In other words, this isn't a bait and switch thing where I say, I do all these surgeries, and you get here, and no, I try to steer everybody to 1 surgery. That's not what happens. There may be some surgeries that I do a little bit more than others, but I do all of these every month. The other thing that you'll see is that I see this as sort of a continuum. You have less invasive surgeries, and you have more invasive surgeries. Okay, and I'm going to cover them kind of in that area, in that way. But I also want you to hear me say, and what you will hear me say, and what you'll see through this is that less invasive could also be equated with less effective. And more invasive generally is more effective, okay? So you can classify the surgeries however you want, but ultimately I think you have to look at all aspects of it. A principle that I've learned, and I want to kind of get across it, and I think it will, is that the more invasive or the more you do, generally the more successful we are. For me, it's important that the patients have a big part in the decision because I want them to buy into it. I want them to believe in what they're doing. Educate people so that they can make an informed decision, because that's what this is all about. Make an informed decision, and then once they make that decision, then we try to help them get the best result they can. Okay, so this slide will begin to help us think about how the 4 different surgeries are maybe similar and a little bit different, okay? And you can see we've kind of grouped them a little bit, and you'll see that we've grouped them by how they work. Okay, so you see at the top of each of these slides a word, and you see over here on the top left restriction, and then you see down here we see malabsorption, and then we see combined here. And the reality is that while these surgeries that I've listed over here work purely by restriction, actually both of these surgeries work by some combination, but the one that has the most malabsorption is this one here that some of you may or may not have heard of before, called duodenal switch. And this is the one surgery that you'll hear about today that you probably wouldn't hear about at most seminars because nobody else around here does that procedure. Okay? The spectrum, basically goes from less invasive. The purely restrictive operations that I've listed over here usually are considered less invasive, okay, because it has less change to your body, less permanent change, and because it doesn't involve any malabsorption. The other surgeries, gastric bypass and duodenal switch, are going to be considered more invasive because it's going to change your body more and because it's going to add some malabsorption. So first thing we're going to do is look at some pictures. And we're going to start with lap band. Has anybody ever heard of lap band surgery before? Yeah. I kind of say that jokingly because, and I dubbed Dallas, Texas, the lap band capital of the world. I want you to understand how I see it fits into the sort of the spectrum of procedures that I do, and how I see it fitting into the spectrum of surgeries in general. What I don't think is that lap band is for everybody. It is the least invasive procedure that we do in a couple of senses. One is that we don't really alter your body permanently in any way, okay? The band can be put in and it can be taken out. One misconception I find a lot of people have is that the band is intended to be put in and then taken out once you lose the weight. Okay, that's not true. It is intended to be implanted and remain there permanently, the rest of your life. But the procedure is done laparoscopically, so therefore that's less invasive too, less pain, smaller incisions. It can be done often as an outpatient procedure. In other words, you don't have to stay in the hospital overnight, okay? And so those are the reasons why we think of it as being less invasive or sort of minimally invasive, those types of terms that we use. The band is placed around the top of the stomach near the esophagus. So you end up with a small stomach above the band that we refer to as the stomach pouch. And the way the band is designed to work is that it regulates the flow of food through that point so that when you eat, the food will fill up that stomach pouch, that top of the stomach, and then it'll stay there, okay? So that's what when we say restriction, that's what we're talking about. It restricts how much you can eat at a given moment, okay? So there is no real change in how you digest your food or what you absorb, how much you absorb. You should absorb basically everything that you would absorb before the surgery. And so restriction basically means you eat less, okay? And again, part of the restriction is that the surgical restriction and the change in the anatomy is that you eat less, but you don't have as much problem with hunger, because obviously hunger is a big problem when you try to cut your portions down, right? So it stretches that part of the stomach out. You have little nerve endings on the top of the stomach, and that sends a signal back to your brain that you're full, or that you don't need to eat anymore. And if we can make that last for several hours until your next meal, then you will eat less. Okay. Now restriction has a little bit of a weakness, and that is that it works really well if you eat solid food and if your band is adjusted correctly and you eat 3 meals a day, okay? But it doesn't work very well if you take a lot of liquid foods or a lot of foods that flow through the band area very easily into the rest of the stomach, and if you eat frequently or almost constantly through the day. You do have to make some good decisions about what you're going to eat and when you're going to eat, okay, for this to be effective. Now, having said that, it's very effective for for some people. Some people do very well with lap band, okay? And they're able to make those adjustments to their eating, and they're able to lose everything that they need to lose. But one thing that we see with the lap band procedure, just in general, is that the results are a little bit more variable. So the good things are less invasive, quick recovery, you can adjust it to kind of customize it for each person. The way the adjustments are done is you see attached to that band around the stomach there's a tubing that comes out to this thing right here we call the port. Okay, the port